The last speaker for the session is Drs. Danielle Serrano and Marlise Osterman, who will be summarizing ADQI 33, Role of Sex and Gender in AKI, or SexXY ADQI.
Thanks for that, Kat. All right, so as Marlise is coming to the stage, so we're going to go quickly. We'll try and stay on time. But yes, this is the report out from the ADQI that we just held a couple days ago, and we're really going to spend most of the time talking about the rationale, and then Dr. Osterman will wrap us up with our key statements. This is the group, but really a lot of gratitude for the faculty and, of course, the executive committee of ADQI for allowing us to talk about this topic. We did have industry sponsors. They were not part of our consensus statements, but we are very grateful for their support. So who here thinks that our field does an adequate job distinguishing sex from gender? Anyone? Including considerations of sex biases in our preclinical research, including considerations of sex and gender biases in our clinical research? How about considering the impacts of sex and gender on our clinical care? And so just to take a step back, sex is a biological variable which includes anatomy, sex hormones, sex chromosomes, and gender is a societal construct which really has to do with how we interact in society. I have it easy. In my lab, I study mice, and they have no gender. There's only sex, whereas all of us who take care of patients or who study patients have to deal with both sex and potentially the role of gender. There are known anatomical differences between men and women, or males and females, I should say, for renal physiology, and I won't list them. You can read them. And then Lisa Curtis just did a wonderful review in Kidney 360 about sex and gender differences in AKI, so I'm actually going to use her framework to march through what we know. So let's start with the obvious. Females have 2 X chromosomes, males have an X and a Y. The Y chromosome has the SRE gene that induces testes formation. Now, most of us are, if we recall from medical school, we learned that we have 2 X chromosomes, and that second chromosome is silenced or inactivated, so the females don't walk around with double dosing of those genes. However, that's not actually what happens in reality. In reality, some of those genes escape inactivation, and so females have an extra dose of some of those genes. And it's 3% in rodents, and 10% of human X chromosomes escape this inactivation. On the flip side, males, of course, have a Y chromosome that females are lacking. Now, the Y chromosome, as I mentioned, the main job is that SRE gene that induces testes formation, but there are quite a few other proteins encoded on the Y chromosome that obviously females do not have. The impact that this chromosomal difference has, and potentially epigenetic roles as well, is vastly understudied. Rather, we tend to focus solely on sex hormones. Now, sex hormones influence the inflammatory response, nitrous oxide and neurovascular modulation, and of course mitochondrial and oxidative stress. In general, females are less inflamed, more relaxed, and have better mitochondrial function. And that's a gender-related joke, not a sex joke. JJ's laughing in the audience. Now, Dr. Forney last year debated Dr. Panu and I as to whether sex mattered in AKI, and he taught us about the castration of Uranus. Now, long story short, Uranus was the god of the sky and heavens and was a real jerk. And he banished most of his children to hell because he was worried they were going to usurp him. He should have banished them all because one night his son Kronos, also known as Saturn, snuck into his bedchamber and castrated him. Now, we can all agree that this is horrific, but on the plus side, he was now less susceptible to ischemia reperfusion, acute kidney injury. This is work by Joe van Ventry's group about 20 years ago now, and he demonstrated, and top panel here, just to orient you, top panel were males, bottom panel is females, and in general, he gave them both bilateral ischemia reperfusion injury, equal clamp times for both sexes, and he demonstrated that males were more susceptible to injury. Castration reduced the injury, and then if you give testosterone to either the castrated males or to intact females, that injury susceptibility was increased again. Trying to block testosterone via an androgen receptor blocker did not improve outcomes. So in general, testosterone more than estrogen accounts for ischemia, reperfusion, sex differences via non-androgen receptor mechanisms. This is really foundational work, but on the flip side, it actually led our field to kind of ignoring females entirely in preclinical models. So, estrogen is protective, testosterone is deleterious, and the vast majority of animal models now focus exclusively on males. Lisa then went on to talk about, well, what about sex hormones across the lifespan, and how does that potentially interplay with our in AKI? And of course, we know that estrogens, FSH, as well as luteinizing hormone, shifts throughout the lifespan. But then there's also quite a big of difference in testosterone levels across the lifespan. And so while we think a lot, I think socially about menopause, andropause also occurs. And then, of course, during puberty, things are very active as well. And so we described this in this concept in the pediatric ADQI, the 26th ADQI, and this was our figure describing development as a biological variable. And this is really just showing the life course of kidney health, knowing that as neonates, kidney function is, about a term GFR is about 30 mils per minute per 1.73 meters squared, and children reach their adult normative GFRs by about 2 years of age. And so kidney function is blossoming through early childhood, then it plateaus in early adulthood, and then of course declines with aging. And what we think we know, but we don't really know, is that it probably matters if you have your AKI episode at 2 days of life, 2 months of life, 2 years of life, or 20 years of life. And what we also called out was, well, what about these sex biases? So we know that estrogen and testosterone interact with your AKI outcomes. What happens if you're prepubertal versus postpubertal? Premenopausal, postmenopausal. And so one of the things we wanted to think about during this ADQI was how might development as a biological variable and sex as a biological variable overlap and interact across the lifespan. So what happens to baby boys and girls with maternal, circulating maternal hormones? What happens pre and puberty? What happens with menopause and andropause? And what could the potential implications be for research if we're not looking at the results unpooled with regards to sex and not unpooled with regards to pubertal status or menopausal status? Shifting towards clinical studies, it gets quite a bit muddied. So in 2012, the KDIGO AKI Care Bundle describes female sex as a risk factor for AKI, but in the meantime, Joel Newgarden has done some very nice meta-analyses showing the exact opposite. Nish and I did a review last year where we looked at sex and gender in AKI studies, and if we just focus on the effect of female sex on AKI, some studies showed that it was harmful, some showed that it was protective, and some showed no difference. Again, this is probably complicated by the large age range of adult women being included and spanning pre, peri, and postmenopausal status. And this really brings me to Simpson's paradox, which lives rent-free in my head. I worry about it a lot as a researcher. This is the statistical phenomenon where an association between two variables in a population emerges, disappears, or reverses when the population is divided into subpopulations. So simply put, we can convince ourselves of a very nice association here. But then if we add one more variable, it becomes very clear that we were interpreting the results completely opposite. And so we might be missing the forest for the trees sometimes if we're neglecting to think about variables such as sex. And so now for the really complicated part, how might gender impact access to care? So we've been talking about sex as a biological variable, i.e. anatomy, hormones, and chromosomes. But what if we intersect that with all the things in society, like if you have access to care because you're a woman or a man? And then what about intersex patients? It's not common, but they exist. We might not know about them, but they're in our clinical studies. And then how about transgendered patients who might be receiving puberty blockers or hormone therapy? And so this is one of my favorite quotations. The whole problem with the world is that fools and fanatics are always so certain of themselves, but wise are people so full of doubts. One of the big goals of the ADQI was to make sure that no one in our field is still hanging out here at the top of that Dunning-Kruger curve, completely oblivious to the important role of sex and gender. If we're thinking about it, we should be a little bit more confused and uncertain. So hopefully the ADQI will help us kind of crawl out of this insecure canyon together with some rigor, and learn what might be out there as far as novel therapeutic targets, given some protective sex biases if we can discover them. So the mission for the ADQI was to investigate the role of sex and gender on the development of AKI and outcomes, explore how these biases may be present in diagnostics and AKI definition and biomarkers, and then how might this impact responses to drug therapeutics and extracorporeal therapies with regards to sex, and then how might the diverse sociocultural influence of AKI be impacting our patients, and then how can we train our mentees to be incorporating these important aspects of sex and gender in research. And with that, I'll go ahead and hand it over to Dr. Asterman.
Thanks, Danielle. So in the next remaining 3 minutes, I'll just tell you very briefly what these 5 working groups discussed. I'm afraid at the moment we're not ready to reveal and show you the statements and the rationale yet, but it's work in progress, and hopefully we'll present it next time when we all get together. So we had 5 working groups, and they focused on different aspects related to the theme as described by Danielle. So working group 1 consisted predominantly of preclinical researchers led by Lisa Curtis. You've already heard a lot of her work. And they focused on the results from preclinical studies where mice or other animals get investigated. And they focused on, as shown here, the sex differences as identified in these preclinical models, the underlying mechanisms, and they also looked at the potential impact of non-renal diseases on sex differences. Group 2 looked at the results and the biological results in humans and the epidemiology, plus the implications for clinical research. So as listed here, they explored what we know about sex differences in humans, the pathophysiology and differences between men and women related to AKI development, and the epidemiology as described in the literature, plus implications for future research in humans. Group 3 looked at the management of AKI at the bedside and focused on the 5 R's as shown here. So what are the implications for risk assessment, recognition of AKI, treatment of AKI, response to treatment, and rehabilitation? Are there differences with regards to the clinical management of people with acute kidney injury, taking sex and gender as variables into account? Now, group 4 focused on the social determinants of health, and as Danielle elegantly described, they really focused on gender, implications in society, socio-cultural aspects, and the whole treatment of AKI across the world. And these were their key questions. Which social determinants of health influence health equity? Does sex influence health equity in the continuum? And are there any other particular aspects that need to be assessed? And we really also looked at equity, access to care across the world. And I think this is particularly relevant today on World Kidney Day with the theme of equity to AKI care and access to AKI care. And then lastly, the last group number 5, focused on the implications for education and workforce and addressed the question, what do we need to do to raise more awareness amongst all stakeholders, clinicians, non-clinicians, policymakers, societies, organizations, and what is required to implement change in our understanding, but also in the way we manage acute kidney injury amongst the different genders and sexes. And then went further and said, how do we judge performance, and what should be the key indicators to determine that progress has been made in this field. So these are the themes. We did come to some consensus. We have formulated consensus statements. They're not quite ready for presentation yet, but as a group, with the sponsorship of our generous educational sponsors, we will work on this and hopefully get this paper published in the next few months. Thank you very much to everybody who contributed.